Okay, this first case I want to show, to discuss and show some findings related to the presence of pneumomediastinum, the chest wall subcutaneous emphysema supraclavicular, as well as air in the upper abdomen. And one thing that was on the report of a CT that was read here was a description of possible diaphragm rupture, which sounded pretty awful in the context of that report. And certainly there's no findings to suggest that. As best I can remember, this was probably ascribed to the Macklin phenomenon, but it was not a trauma patient, and it's also not a patient with intra-abdominal disease. So the point of showing this, and I'll now show you the abdominal CT so that you can see the distribution of air, but particularly the air in the upper abdomen. So we have here, you can see where the air is in the upper abdomen. And I want to show this just to remind myself, as well as my resident, and I showed my resident and everyone else, that there is a pathway by which mediastinal air can traverse from the chest into the upper anterior abdominal extra-peritoneal space. And that's via the so-called sternocostal triangles or the foramen of Morgagni. So here we see a lot of air traversing that region, and then we see the air in the upper abdomen. But just to remind myself again, other than maybe a little bit there, there's maybe not even that, there's extra-peritoneal, or at least extra-peritoneal air. So anterior retroperitoneum. And this is the classic article that goes way back now to 1978, I think it is, describing that pathway by which one can get transdiaphragmatic passage of air from the mediastinum into the upper abdomen. And I think this article focused primarily on the pediatric population, and just a nice example of that in this particular case that I'm showing, and certainly not something that deserves remotely the label of diaphragm rupture. And this might be a COVID patient, but I must admit right now I can't quite remember. I think this was attributed to the Macklin phenomenon. So just a reminder of that particular pathway as an explanation for connecting up the air. This one is I'm going to show you two cases for which I just happen to have nice images from a lung biopsy, a surgical lung biopsy. So in terms of, if I can bring this up, how one would potentially label or think what diseases one would think of for this interstitial fibrosing lung disorder. It is basal predominant disease. I'll just emphasize a couple of things that I think of. When I see the absence of, in the lung bases, subpleural traction bronchiectasis and honeycombing, I'm beginning to think at least a little bit away from UIP. And now there is reticulation there, of course. And if I see findings consistent with traction bronchiectasis away from the pleural surfaces, but airway centric, and potentially in looking at the lungs, areas of lobular air trapping, I certainly think of fibrotic hypersensitivity pneumonitis. So for example, here's a focus of traction bronchiectasis. So let me show you some nice images of the biopsy. I'll make that big. This was read out as fibrotic HP. So in pathology, the pathologist made a very big deal about airway-centric fibrosis. Here's some scarred airways. Here is a place where we have some subpleural scarring and bronchiectasis, but accumulation of lymphocytes, maybe not quite with the lymphoid follicle in relation to airways. There were some regions of NSIP-like interstitial fibrosis. And then the other thing that pathologists look for when looking at airways and the airway-centric fibrosis is bronchiolar metaplasia, when there's extension of respiratory epithelium away from bronchioles, and sometimes even involving alveoli. So this pathologically is a case of fibrotic HP. And I'll show you.
Were there any poorly formed granulomas, and was there an antigen?
Nope, neither.
Because we've certainly seen patients that have, they have UIP plus, or they have fibroblastic foci. Were there any in this case? Because you'll occasionally see UIP with additional bronchiolocentric fibrosis, and those are the ones that are tough and often end up, in our classifications, still end up being classified ultimately as UIP.
Yeah, I think in terms of fibroblastic foci, if they are few in number and if they are more airway centric rather than at the leading edge between, in UIP, at the leading edge between the areas of fibrosis and relatively normal lung, then they tend to, they say that you can see those kind of fibroblastic foci in fibrotic HP. So that you can see, if I understand your question correctly, fibroblastic foci in fibrotic HP.
Was there any known exposure in this patient?
No.
No, okay.
No. Here is another one. So let me show you the images. This is from the outside, so I don't have really nice thin 1 millimeter. Well, I think I do actually to show you, but that's what the lungs look like. And let's take a look at this one. So I'll scroll down and show you the distribution of the opacities in the upper lung zones to the lower lung zones. Again, in looking at the lower lung zones, there's a rather conspicuous absence of at least basilar subpleural traction bronchiectasis and no definite honeycombing. And you can see again that away from the pleural surfaces, there are areas of, one can infer, traction bronchiectasis or airway-centric fibrosis, for example, here. Now, in terms of, say, just the UIP, I would have to choose between labeling this as indeterminate versus that last category of suggestive of another diagnosis. And I know there's going to be intra and even inter-observer variation in that label. There's a new scheme for fibrotic HP, which is typical or consistent with and not. And this, I don't have any images to look for air trapping, so I would put that in that middle category for fibrotic HP, and I'll show you that in a moment. Before I show you the pathology, would anyone feel strongly about trying to distinguish between those two? And of course, my focus here is between UIP and fibrotic HP.
So Howard, a couple things you were referencing the new, is it I think it's an ATS document on,
okay. Right.
Yeah,
ATS.
It's a nice paper. I find it hard to use because it plays into the UIP one. So I don't know. I get what they're coming at. It's a nice framework, but I think you have to constantly go back to UIP one. Anyway, with your case, I think the relative, I like indeterminate when it looks like UIP, but it's not basal predominant, or there's just a little too much ground glass. I think yours has a lot too much ground glass, and I think it's much more upper lung predominant, and there's a lot more central disease. So I have found most of these cases turn out to be either HP. I'd like it to be a little more heterogeneous, but fair enough, it can go either way. The air trapping's variable, or connective tissue disease with a non-classic NSIP pattern. Very few of these, in my experience, are ever called IPF, at least in our institution. We often find something else.
Yeah, I agree. I genuinely agree exactly with that.
I would say, yeah, I agree. We would say this is suggestive of an alternative diagnosis based on the distribution. We have had a couple of familial cases that end up being eventual diagnosis of like familial fibrosis with UIP on biopsy.
Yeah. Okay, good. This one, again, I really have nice labeled images for you because this has many findings consistent with fibrotic HP. So here the arrows in this section show numerous loose, non-necrotizing peri-airway granulomas, an image showing granulomatous inflammation, and remodeling of airways with what the pathologists call peribronchiolar metaplasia. Here's an image showing a nice interstitial granuloma. Here are some scarred airways. Here, and this one can certainly see with both non-fibrotic, but even with fibrotic hypersensitivity pneumonitis, that one may see expansion of the interalveolar septum by cells. So either an NSIP or a fibrotic NSIP. Here is a case of rare fibroblastic foci in this patient. And that's it. So this patient was labeled under the microscope as fibrotic HP in this patient. Okay, I'll stop there for the time being. I have some other cases, but I can show them later or another time, Jeff.
All right, thanks, Howard. We appreciate the path. That's always so fun to look at. And
yeah, it's nice that I've got a pathologist that will label it for me. It's kind
yeah,
of
no,
yeah, I still, with that one definitely, even if you don't have an antigen, I think is everyone's comfortable calling HP. I still think the first case, I'd be a little, we would not label that HP without any granulomas and without any exposure.
Okay. Yeah, there's definitely a variation among pathologists. Yeah. Fibrotic HP, I think it's easy to say, is hard for even expert pulmonary pathologists.
Because as you were pointing out, there was some bronchiolocentric fibrosis and peribronchial peribronchiolar metaplasia, but those are findings you can see with IPF.
Right. Sometimes some pathologists make a sort of a semi-quantitative measure of the fibroblastic foci and the other findings, and they get to some threshold where they call something. But that's the intra-observer variation that definitely exists in the world of even the expert pulmonary pathologists.
Yeah, and I've seen a trend with the younger pathologists, and I think it's probably the right thing to do, of becoming more descriptive for these cases that don't have all the features, and they give a differential diagnosis, but they don't give HP as a diagnosis, but they more of a descriptive pattern and suggest. Because I'd wonder about also a connective tissue disease with some of those findings when you don't have all the classic HP findings. And now that there's all the extended myositis panels and other ones, I'm surprised. We often are starting to see picking up some new autoantibodies. So I think that unclassifiable bucket is still available to us and still a wise one to use. But over time, many of those patients, we ultimately reach a diagnosis of something else, whether it's familial or a sort of an unusual connective tissue disease. Okay, who would like to go next?
I can go if you want me to.
Yeah, that'd be great.
Let me make sure what's going on here. All right. So this is a case. Well, I'll show this case first. This was a guy who came in and had not the prettiest study, not the best phase for it, but had this chest pain, had a severe LAD stenosis. I don't know why, but it seems like our cardiologists are getting coronary CTs in the ER with people with chest pain and actually troponin bumps, which to me is not what it's used for, but and we tell them that, but they still get it. Anyways, this guy's never had a sternotomy, never had anything done to him. You can see there's this kind of hypervascular lesion here, and in some phases it looked like it was coming off maybe an acute marginal artery. Let's see, do I have a better phase? I thought I had a better phase. And just so here's the non-con, and you can kind of see that this doesn't it's not a calcified thing. It's clearly an enhancing structure. So we thought it was, going to be a pseudoaneurysm. Now the interesting thing is that, let's see if I can pull this up quickly without delaying too much here. So they did a cath, and the cath showed as severe LAD stenosis, and yeah, this is not a good picture, but the RCA looked fine. There was no evidence of a pseudoaneurysm or anything coming off the vessels. We weren't sure, maybe it was hiding back there, but they did their multiple rotations. The other injections were pretty crappy, but there was nothing clearly definitively coming off. So we were kind of stumped. We don't know what the answer is, or what to think of it. We surmised, could it be a hypervascular tumor? We know that angiosarcs start in this location, but again, you would expect that to be so hypervascular you would see it on the cath. So I don't know if anyone has any other thoughts. We're still thinking maybe cath just didn't see it because of the angles they got, but we're kind of stumped on this one. And I asked one of my junior colleagues, and they said, oh, it could be a so like a little hemangioma or some other hypervascular tumor, which again, I've not seen in this location, but I really thought that didn't make sense. And then she showed me this case, which I thought was fascinating. So here is, this is an outside study, and you can see there's this kind of similar, I'm sorry?
Go ahead.
Similar appearing hypervascular lesion off the RCA. Let me go to our CT if I can find it. Yeah, whatever. Here's another outside CT on it. And it's just never really well seen. We did a coronary CT on it. It wasn't well seen. You see it, but it's just not. There's always motion right in this region. We did an MRI, and it just wasn't done well, and it's hard to see this little thing, especially in the coronaries. But the interesting thing about this guy is here is the a neck MR, and you can see this hypervascular region around the carotid artery. And this patient had, it turns out, don't remember the mutation, that MDHB or something mutation regarding with paragangliomas. And it turns out that they did a F-DOPA PET, which is what you want for paragangliomas. And this thing is red hot on the PET. And then here's the neck thing. So this was a paraganglioma in some, around the coronary in some guy with one of these metastatic paraganglioma kind of syndromes, or what, the multifocal paraganglioma syndrome. So I thought that was pretty crazy.
Oh, Seth, this is the comparison patient, not your original patient, right?
No, this is comparison patient. So this is this is one patient. And then this was the patient that we saw. I don't know why this phase got sent over. I must have sent the wrong phase. This is the patient that we saw, the patient with the paragangliomas, that was from like 2 years ago. This is a patient we just saw a couple weeks ago, and still not really sure what it is. They don't really care. The cardiologist, he's 78. They don't seem that concerned. We're telling them to get potentially an MR or other. Yeah, Jeff, can you put SDHD mutation? That's probably right. Yeah, so I don't know what this is.
It's
But-
funny, the textbooks wouldn't tell us to look for paragangliomas in those particular locations.
No, yeah. I mean, I've seen lots of I've seen maybe 5 or 6 cardiac paragangliomas. You know, and I've not seen one that is that small, just sitting right in there. And this guy doesn't have any mutation. I just don't, and you can almost see there's a little vessel going into it. We're just not sure why the cath it didn't get seen on the cath. We're convinced kind of that if they did some better injections at different angles, it might have come off. But again, he has no explanation. He's never been cath. I mean, you don't randomly develop pseudoaneurysms. He has no atherosclerotic disease here. He's never been cath. He's never had trauma. But I guess it's just a mystery. We're never going to know.
I think I've seen one single AV groove paraganglioma in my entire career. I think once. It turned out to be a paraganglioma in the right AV groove.
No, I mean, it could be a paraganglioma, it could be a meningioma, it could be an early angiosarcoma. I mean, who knows? It just, you know, they don't really, they're like, oh, just medical treatment for the LAD, severe LAD stenosis, because it's single disease with the new ischemia trials. This case I shared with some people. This is a young kid, came in, pneumomediastinum, parenchymal abnormality, was called COVID. Underwent some COVID tests, which were negative, but it was still thought to be COVID. They got a CT. It was read at night by one of our call people. It was called COVID, even though there's lots of features here that aren't good for COVID, a lot of central lobular nodules, and then kind of that beautiful sparing of the peribronchovascular interstitium. I mean, really just gorgeous. One of the nicer cases I've seen with it. Central sparing, peribronchovascular or subpleural sparing, central sparing. And, you know, we came in the morning and one of my colleagues, actually, don't even ask me why, they did another CT like 6 hours later. Who knows what they were looking for. Oh, they thought he had COVID and he continued to have shortness of breath and they got a PE study. So, which didn't show COVID or PE. But on the second study, my colleague read it and very nicely said, you know, concern for inhalational injury such as EVALI. And then it turns out he vapes marijuana every day. So not gone yet. You know, we're still seeing some cases. I mean, very beautiful. So a very classic case of EVALI. And the last case is just a cool case. Nothing really that's super special about it, but I just liked it. I was reading this the other day as a cancer follow-up and noticed this vessel here, which was kind of odd. And it's not your typical left-sided SVC. It's more along this, it's contiguous with the cardiac veins. And you can see that it's kind of, doesn't take the typical location of at left SVC. It more looks like a middle cardiac vein going into the creator cardiac vein. And then it goes up and connects with the brachiocephalic vein. And if you notice here that the kind of, that there's really no connection here between the coronary sinus and the right atrium across the you know, Thebesian valve. So this patient has, and you can even tell by the flow of contrast which way this blood is flowing. It's not flowing from the left-sided brachiocephalic vein or the left brachiocephalic vein down. This is flowing up, because if you look at the contrast in this vein is quite dark, and this contrast is quite bright, which goes with the contrast in the coronary sinus. So basically, it's osteoatresia of the coronary sinus with just a kind of an anomalous venous drainage into the left brachiocephalic vein. And it's uncommon. I mean, it's not unheard of, but it's just a nice, kind of a nice, just random finding on a cancer follow-up. You got to make the cancer follow-ups fun somehow.
So I've shown a couple of those, you probably remember. And yeah, I still don't have one on a gated study. This is as good as of an example as I've seen. But I think the one, you know, as you probably read too, the one complication you can have is venous myocardial infarcts if that's ligated for some reason.
Yeah,
I think that's the only, yeah. And I don't know, maybe we should write up the collection of these that we have.
I have to pull it up. I showed one maybe, God, it's sad, like 9 years ago now, 8 years ago now, that was a gated study. But that's the only one I've ever seen on a gated study.
Because I've probably got 4 or 5 of them, and you've got a few. I think it's an important finding just for that reason to recognize.
Yeah, you definitely do not want to screw with this vein for any reason, because you will basically destroy the coronary outflow, coronary vein outflow, which would be very bad. So anyways, Jeff, those are my cases.
Awesome, thanks. All right, Travis, you wanted to go. Let me make you the presenter.
I'll just show one case. Howard, I waited for you to come back to show this one since I was going to show it last week. This is a patient who came in December, and I think I was involved with this over the weekend. He has back pain and recent onset of lower extremity paresthesias and weakness, and not a subtle abnormality here. You can see there's a little bit of a hilum overlay. It sneaks above the clavicles, so some of the cervicothoracic sign too. And so it looks like it's probably either in the lung or posterior mediastinum involving the lung. And I don't know if I can window it.
That is the anti-cervicothoracic sign. In other words, in other words, and correct me if I'm wrong, but if we're seeing a well-defined interface between the superior part of this opacity and the lung, and it's well-defined like that, then that is the non-cervicothoracic sign.
I never remember which one's which, but the idea is, you have a complete margin up here, so it's probably not anterior.
Right.
Yeah. And then I think that if you look at the vertebral bodies, you see there are at least a couple of levels where you don't really see much. So this CT, here is this mass, and this guy does not have a primary cancer. And you can see this is an enormous hypervascular mass, and there's a ton of collateral vessels in the chest wall and in the mediastinum as well. And it's involving several levels compressing the canal. So this is, when things get this large, they're hard to localize. I would say this is, looks like it's probably arising in the mediastinum and just secondarily pooching out into the left hemithorax. And so you could say it's posterior mediastinal if you wanted. I think I showed this or shared this briefly with Jeff and Howard just because I didn't know, I hadn't seen anything exactly like this. My first thoughts were some big sarcoma, maybe the world's largest paraganglioma that I've ever seen. And if he had had renal cell carcinoma, maybe a metastasis, which he didn't have. My differential kind of stopped at that point. I'll show you just briefly the MR. You can see all of this internal vascularity. It's T2 hyperintense on the MR and lots of enhancement delayed. They did a biopsy, percutaneous biopsy. They thought it was most consistent with a paraganglioma. And I think this is interesting just to show how many different levels this thing had a contribution from vessels. So this is one of the left-sided intercostal arteries, T8. There was even some right-sided recruitment across midline. So this guy spent almost a day in the neuroangio suite, getting a lot of different arteries embolized. And this was something that was important that I talked about with the surgeon beforehand, recognizing I showed some of those chest wall collaterals, and they were coming off of branches of the left subclavian artery. So I thought it was going to be like I thought it was internal mammary, and some of the other ones, actually it was the thoracoacromial branch or trunk, but you can just see all of these. And they were able to successfully embolize many of these things and took this guy to surgery, took this thing out, and it was, in fact, a humongous paraganglioma. So Seth showed what might be smallest paraganglioma. This might be the largest paraganglioma. Now, I don't know, I don't know, maybe you guys know more about the histopathology of this. They were talking about this. I looked up the Zellballen growth pattern, and that's a typical cell growth pattern for this, but it didn't really talk about the rate or the severity of malignancy. They said they're only rare mitotic figures. So I think it was implying it was of lower malignant potential, but just an enormous paraganglioma.
That's the first posterior mediastinal paraganglioma I've ever seen. Like, and I've seen, we've all seen lots of paragangliomas. I've never seen one. I have one that's that big, but I've never seen one truly in the posterior. I mean, because it's just, there is a plexus back there, but it's just a common one. And look at the bony destruction. I mean, they're locally invasive. I mean, can he walk? Is he paralyzed?
He was not paralyzed. He had weakness, but he was still.
I mean, the thing is like in the cord. I mean, that is just.
Yeah, I know. But yeah, you can see you can just see how much compression there is of the cord there. Cord's just a little, lemon drop in the back there. So.
Yeah.
All right.
Okay, thanks. David or Peter?
I don't have anything this week, Jeff.
That's all right. David?
Hey, Jeff, do you want to share with me for one quick second? I want to show something real quick. Just,
sure.
It'll take.
No problem. We got plenty of time.
Jeff.
Is it this here? So you were talking about the dynamic, tracheomalacia protocol. So this is a guy with tracheomalacia where we're doing kind of dynamic with the Revo, doing dynamic coughing just with repeated rotations. And that's, a positive case, clearly.
That's pretty cool.
And you can do it at any level. Anyways, that's it.
All right, cool. Thanks.
Hey, Seth, could you send me one of those videos? I want to show that to some of the people here. We might start doing that.
Same here. Send it to me as well, please.
Okay.
Yeah, send it out there would be great.
Just send it to the group. David, I'm sorry. Did you have any cases?
Nada.
No, that's all right. Okay, I have a few I can show here. Let's see. It's not what I wanted to do here. Let's see. There we go. Okay, so I'll show this case first because it has nothing to do with the other ones. Yeah, I don't know why my PACS always exports only the lateral. It's very interesting. I'll have to go back and look, but you can see some nodules here, but the CT is what's kind of cool. And so this, you'd be surprised, as much endemic fungus as we have in the Midwest, we don't see a ton of histoplasmomas. And this was cool because this patient didn't have one, but multiple ones. So you can see here's one here. So it's got the soft tissue nodule, and you can see it's got the dense central calcification. And sometimes if you window these, you can actually see they are sort of ring-like. That's a little one in this guy. He had actually a couple of big ones. So this one, he's got this really nice one here in the middle lobe, and I'll window it for you. But you can see that target-like calcification and then the rim of soft tissue around it. And then he's got another one down here. It's kind of the same pattern. And again, if you window it tightly or dark, you can see right there, there's that ring of calcification. So this guy had a bunch of nodules, histoplasmomas, but there's another one there. I've seen one, and on occasion when we see the calcified nodules all the time, I've seen tons of little calcified nodules, but I've never seen nodules this big. And they went back over multiple years, and they do grow. And they're sometimes a little bit warm on PET. We would never do a PET for this, but sometimes you'll see a little FDG activity. Of course, tuberculomas can look like this as well, but still meets criteria for benign pattern of calcification, but no point in following them because they're going to get bigger. But out here in the Midwest, these are histoplasmomas.
Jeff, how about Mr. Spleen? How's Mr. Spleen doing?
Oh, not in this case, but that doesn't exclude it. I would say, David, I see the speckled spleen actually be an interesting to look at, but we don't, I see it most of the time, I don't know, a couple times a week.
Okay.
But yeah, you're absolutely right. It's pretty much a slam dunk histo.
Okay, so one other consideration for this pattern of central calcification is dirophilaria.
Isn't that like
dog
heartworms or something?
What?
Isn't it?
Yeah, that's the dog. It's the dog heartworm.
Yeah.
Yeah. So, and it looks just like that. Very clean nodules. They're typically in the bases because it's blood-borne, so it goes sort of an embolic distribution down to the bases. Very smooth nodules with a nice central calcification like that. So that would be a consideration. Now, I don't know about mediastinal lymph nodes in that equation. I think that's better for histo.
Yeah, I mean, we see these pretty much on almost everyone we scan, it seems like. I'm going to chalk it up to histo, just given the pretest probability. But that's a good point. Yeah, good point about dirophilaria. I can never say that word. The heartworm.
Dirophilaria immitis. Yeah.
Okay, well, good to know. All right, and then these three cases are sort of related. They're all vascular anomalies that I happened to come across in the last couple weeks. So this one is a cool one. My colleague Daniela ran into this case. She saw this funny looking vein here, and you see there is just a little vein that drains into the right atrium from the right lower lobe, but you'll see it's quite big for just a little pulmonary vein. And then there's this area of lung down here that's a little hyperlucent. And then you'll see there's the funny vessel, and unclear if that's airways or some kind of cystic space down there, but something's funny. And then let me just make this a little bigger. But what's kind of cool is we were looking at this, and you can follow this vessel that's in the wall. Looks like it's in the wall of the esophagus here and runs up in the esophageal wall. And then there's a little branch that comes out right here into the right lung, probably in the region of the inferior pulmonary ligament there. Maybe it's a little lower, but I think this is a nice example, a subtle example of systemic arterial supply to just a little portion of the right lower lobe. But of course, these can be sources of hemoptysis because of the high systemic pressure. It looks like, I presume that's some bronchiectasis or something. So maybe at one point there was some bleeding, there's some scar. But the real tip off here, I think, is this, and that was a good observation, is this vein that's just bigger than a pulmonary vein that one expects at this level because it's draining this general vicinity, and it just pops right into the left atrium there. So just a cute vascular case, but this is always in your differential for patients with hemoptysis. The good news is they tend to bleed right in that area. So the blood on the CT, if they have any, will localize to that region. This was just one I came across, and just on I don't remember, this was a PE study for something. And I'm always looking for coronary anomalies because the literature says it's like 1% of caths, but those are probably little peripheral ones we don't see. But I thought this was really cute, and I can't remember. I know I've seen them before, but it's been a while. This RCA comes right off the ascending aorta, well above the sinotubular junction. We're at the level of the PA, and it just slides right down there and goes out and does its business. So just an innocuous variant, but one worth knowing about if you were going to do, say, surgery, you were going to cross clamp the aorta. And I mean, they always do a cath typically, but they are doing, of course, CT in some younger risk patients. Or if the cardiologist was going to go do a cath, they'd probably want to know the coronaries there in advance if possible, but this isn't going to cause any trouble in and of itself. And then in the same week, someone sent me this one. My fellow Melissa sent me this case, I believe. This is a 16-year-old and has a nice, big, juicy left coronary. And you can see there's a branch coming off the LAD that wraps around the infundibulum there and goes out here and becomes the right coronary artery. So it's just a single coronary arterial system with a benign course of the right coronary going between the sternum and the outflow tract there. And you can see this patient's already had a sternotomy, little tiny baby wires, so had some kind of congenital heart disease. So that might explain the coronary anomaly there. And you can see there's a big juicy, it's a left dominant system, so the PDA comes off the circ there. But just two kind of fun coronary variants.
Yeah, very nice.
Yeah, no, single lefts are rare and prepulmonic lefts are rare. Is there anything retroaortic? Sometimes there's, the only time I've ever seen retroaortic RCA
There's a
rights are from, that might be an SA nodal branch.
Yeah, I think you're right. That's exactly what it is. It's coming off the circ right here and slides in there. Yeah, and I've seen that a lot of times. I haven't seen one in a while, but I swear all our COVID patients who get PE studies are so tachycardic that there's too much motion to see that. But yeah, this is an SA nodal branch. But yeah, I can't remember. I'm sure I've seen a couple. We've seen them on this conference, but not a lot of single left systems.
Yeah, no, they're pretty rare.
Okay. Cool. Are they associated with, I mean, I guess any congenital heart disease could be associated with a coronary anomaly. And I don't know what this patient had, if there was some kind of repaired something at the time. So anyway. All right. And that is, I believe, all I had this week. Nothing else too exciting. So we'll end a little early.
I can show a few more if you like. If
that would be
no one
great.
else has.
Yeah, we got about 15 minutes. If you want to show a few more, feel free. Let me make you the presenter. I'm gonna actually I'm gonna mute myself. I just got like 3 texts for consults, so I'll just end it when it's done, but I won't be able to chime in.
Okay, let me show you. This one I actually want to sort of go back, particularly if there are trainees watching today or viewing the video, to Pathophysiology 101. So in reviewing a case like this with a resident, they will readily and correctly make a diagnosis of pulmonary vascular hypertension, mention the enlarged main pulmonary artery, make note of the enlarged right cardiac chambers, maybe note distension of the azygous vein, SVC, elevated CVP, and then stop. And usually I say, well, we need to go a little bit further, because if you analyze the pulmonary vessels, you may be able to take it a bit further. So then I usually teach at least 3 things. Inversion of pulmonary blood flow, chronic pulmonary venous hypertension. Then what Eric Milne called the balanced distribution of pulmonary blood flow, when the vessels in the lungs, arteries, and veins are distended and of the same caliber in the upper and lower lung zones. That goes along with a left to right shunt. And then in analyzing the pulmonary vessels, and this is subtle here, so I am going to put alongside some images from the recon from the CT. But let me try and fix that, what happened there. So let me go back to default. And that. Okay, so let me just make this big for a second. And if you look at the pulmonary vessels, the subtle finding here is the difference in the caliber of the pulmonary vessels in the left upper lobe or left upper lung compared to down here. One can see vessels here, but they're unusually small. So here we have dilatation of vessels, and here we have small vessels. So let me bring that out by showing you that. So if you see an image like that, and you see the difference in the caliber of the vessels in the upper lung zones, say particularly here, and they are just pulmonary arteries, compared to, in this patient, down here, and you have pulmonary hypertension, you should think of chronic pulmonary thromboembolism. Now, what you see, of course, depends on how much and where the intraluminal thromboemboli or organized emboli are in a patient. But of course, if I show you the CTPA, you'll anticipate that we're not going to see much in the way of vessels there, and that we're going to see a lot of clot there. And of course, no surprise that, for example, if I put this alongside, that you're going to see substantially diminished perfusion in multiple areas, but particularly the difference between what we see here and what we don't see there. So let's go to the images here, and I'll quickly show you the distribution of the clot. So that is the explanation for why these vessels are so small and for the findings on chest radiography. Now, usually in a case like this, because we do have a surgeon that does surgical endarterectomies, I asked them if they saved any images of what they took out during surgery. And I've got a really nice bunch of cases of that. But in this particular case, they didn't have that. But the guy said, oh, you might be actually interested in this. So I think they were kind of proud of what they did. So you can see here that someone was taking a picture of the monitor and the pulmonary artery pressure before and after the surgical endarterectomy in the operating room. And I guess they were quite proud of themselves in reducing the pressure in the pulmonary arteries, measured this way at least, pre and post in the operating room. So that was kind of cute. All right. This one I want to show you is something I look for but almost never see. And the first time I heard of a particular term, and I'll show it to you now, is really in England, in the Brits. So there is a patient, I'll just put this one alongside, that has on the left-hand side here some findings of interstitial edema. Now, there are also findings that go along with hypervolemic interstitial lung edema, including a change in the size of the cardiac chambers, a distended azygous vein, and so on. But what I want to show you here is something that, and I've not encountered this term in the United States, but they do use it at least in England, and that is when they see, and this is really subtle, but I look for this, so I always wanted to try and find a case right here. So there is opacity, but it's not right in the postophrenic sulcus, it's just above. And maybe there's one like that on the other side. But this they call a lamellar, L-A-M-E-L-L-A-R, lamellar pleural effusion. But when they use that term, they do emphasize that they do know it's not actually fluid in the pleural space, but it's subvisceral interstitial lung edema. So here's a really nice example. If you go on the web, you might find a couple of cases like this that are labeled lamellar pleural effusion due to subpleural interstitial edema. Certainly that's really unusual compared to the usual things we look for, like peribronchial fluid cuffs, subpleural edema related to the fissures, and septal lines for interstitial lung edema. And perhaps, you know, one misses that because it's really subtle. But I thought I'd show that because I'm pretty confident that's what it is. It's a new finding from before, or a couple of years before, in this person with other findings of mild interstitial edema. Okay, this one is, okay, I'll show this one. This is a patient that came in from the outside already with a diagnosis of something really bad, and they did a, I'm not quite showing it in the right order, but when they ordered a CTPA, you could see that the person recognized that none of the contrast medium injected through an upper extremity vein made it into the right atrium. Instead, the contrast medium deviated substantially into all kinds of collateral vessels. So they actually injected the patient, I'm sure not by a power injector, but they injected the patient via a lower extremity vein. And of course, you'll see exactly why the contrast medium injected in the arm didn't get there. So this is coming from below, and there's a very large mass that involves the right atrium. And you can see the effects here. This, I think I saw this subsequently in an abdominal CT, and it's going to show the same findings of a very large tumor. Now they biopsied this via a vein. So here is the way they biopsied the lesion in the atrium that showed a tumor, of course. And here I want to show you that it's a bad tumor, but even though they used a lot of different kinds of markers, cell surface markers, everything was almost negative except for some cytokeratins. So even in this patient with a history of a urothelial carcinoma, they really didn't know how to categorize this entirely, but it's a poorly differentiated carcinoma in the atrium. And in another description, I noticed that they also described rhomboid cells. So this is worth knowing. It's, you know, in the category of really bad, big mediastinal tumors. One of the things that we've talked about before and shown before is the NUT, N-U-T, NUT carcinoma. It's not necessarily a midline carcinoma. It used to be called NUT midline carcinoma, but a very bad actor presents with a very large tumor. NUT carcinoma is one thing to think of. In this patient, the patient is a smoker, and there is something that I didn't know about until very recently related to pathology, which is something one should think of if you have a very large tumor. That's a bad actor, something like this, and that is a category of tumors that are called SMARCA4 deficient cancers. Now, they don't only occur in the chest, and it's a particular variety or a variant of non-small cell carcinoma now that they can look for deficiencies in this, and there's no way one can remember what this SMARC stands for because it's way too long. But if you remember that and suggest the possibility when you see such a big tumor of a SMARCA4 deficient thoracic tumor in a smoker, a cancer, a lung cancer, suggest this possibility. They can, in my hospital, they didn't send this out because the patient died and they didn't want to impose additional costs on the patient's family, but they can do immunohistochemistry for this particular, and I can't remember what that stands for, immunohistochemistry to see the absence of that particular item to diagnose the so-called SMARCA4 deficient thoracic carcinomas. So this person may actually have one, but we'll never know for certain because this was bad and he died fairly soon thereafter. All right, I'll stop there. The end of the hour.
All right, thank you, Howard.
Okay.
All right, thanks everybody, and we'll talk again next week.
Thank you.